So welcome everyone to everyone who's joined our first Zoom webinar event. My name is Zoe. I'm Chief Executive of Health Watch Bucks, and I'll be chairing this evening's event. At this particular time, it's really important that patients and their relatives have as much information as possible about how cancer services are working and the plans for how these are going to operate in the coming months. As such, we're really pleased to be hosting this event in conjunction with Buckinghamshire Healthcare NHS Trust. For anyone who hasn't come across Health Watch Bucks before, we're the independent champion of people using health and care services. We're here to listen to you and work with the people that run your services to make them better. Our vision is that your experiences, ideas and opinions make a change for the better in health and social care in Buckinghamshire. So we're really pleased to be joined by this evening by 6 panellists, and I will let them introduce themselves, starting with Andrew.
Good evening, and thank you very much to Zoe and Health Watch for inviting us. My name is Andrew McLaren. I'm a general surgeon in Buckinghamshire. I've been here since 2004, and I specialise in breast cancer and thyroid cancer, but I'm also the cancer lead for the Trust.
Thank you. If we can move on to Raj.
Evening, everybody. Thanks for having me. I'm a GP and Plan Care Director at Buckinghamshire Clinical Commissioning Group, and within that portfolio is cancer.
Thank you. If we move on to Dr. Cheryl Sim.
Good evening, I'm Cheryl Sim. I'm a medical oncologist in Bucks and the lead oncologist. I specialise in lung cancer and gynecological cancer.
Thank you. Ruth?
Yes, hi. Afternoon, everyone. My name is Ruth Wilcoxon. I'm the Managing Director of the Thames Valley Cancer Alliance. Really grateful to be joining everyone this evening. As an alliance, we bring together the clinical and managerial leaders from across the whole of the Thames Valley to have a focus specifically on how we transform the diagnosis, treatment and care for our population across 2.3 million population footprint. Thank you.
Thank you. Annie?
Hello everyone, I'm Annie Richards. I'm the Macmillan Consultant Nurse in Cancer for Buckinghamshire Healthcare NHS Trust, and I've been working in cancer for over 25 years and I've been with the Trust since 2004.
Okay, and last but not least, Leslie.
Hello, I'm Leslie Clifford. I'm Associate Director of Communications at the Trust. And I'm delighted that so many of you have joined us here today. So thank you very much. And thank you very much on behalf of the Trust to all of our panellists for giving up their time this evening. Really appreciate it. Thank you.
Absolutely, thank you. So I'm just going to run through a few housekeeping points before handing back to Andrew, who will give a short presentation. And this presentation will be followed by a Q&A session. So just to note, we're recording this event and it'll be posted on our website over the next few days alongside a summary of the Q&A session. We'll also be publishing a summary report on this event, and we'll be sure not to include any personal details in this. We'll also ensure that questions are anonymised so that people can't be identified. As you may have noticed, we're running this event in webinar mode, so you'll not be able to turn your camera or microphone on and we can't see or hear you. So if I could now hand over to Andrew, who will go through his presentation, Cancer in Buckinghamshire. Andrew, thank you.
Thanks very much. So if we could have the first slide up. So as I said, we're really grateful that Health Watch are hosting this webinar today. And really the aim of the evening is to share some of the impact of the pandemic, the COVID pandemic, on cancer services in Bucks and how we've managed to deal with them and continue providing, in most cases, high quality cancer care. And also to show you what we are planning for the future. If you go to the next slide. Thank you. So patients who are seen in their general practices with symptoms that might be cancer are referred to the hospital on rapid diagnostic pathways, the so-called 2-week wait pathways. And the chart here shows the effect of the pandemic. And if we start over on the left, you can see that roughly 400 patients a month were a week were being referred to the hospital by general practices across Buckinghamshire at the end of February. And then each point along the chart is each week, and you can see that there was a massive drop-off in March, flowing through into April before things started picking back up. And we went down to a low point of fewer than 100 people a week being referred for a potential cancer diagnosis. Now, I must stress that not everybody referred from general practice has a cancer, and we are really keen to see patients being referred who have symptoms that are suggestive of cancer, where we can rapidly reassure them they're not. Only 1 in 14 people referred end up with a cancer diagnosis. The vast majority of people, we are hoping to very quickly reassure that all is well. If we go to the next slide, please. So one of the key areas where referrals are still low is for symptoms of prostatic disease. And prostate cancer is now one of the commonest cancers in the country, and it's important that men are coming forwards with symptoms of urinary difficulty. And really important that we understand that that is something that we are keen to investigate. And if you go to your GP, there are simple tests that can be done to exclude prostate cancer. An early diagnosis for prostate cancer is extremely important. So please encourage anybody you know who's having urinary symptoms to come to their GPs early. And linking to that early diagnosis, we have restarted screening across Buckinghamshire for the 3 cancers where screening is offered. That's breast cancer, bowel cancer, and cancer of the cervix. And those programs are back live now after a short pause during the pandemic. But how can you help us to help you? Well, preventing cancer is super important. And I think it's important that we all recognize that there are a number of things that we can do to reduce our risk of cancer. Biggest one being to stop smoking and reduce smoking where people can't stop completely. But also recognizing that 65% of adults in Buckinghamshire are overweight. And that little bit of extra weight, even 1 or 2 stone, very significantly increases the risk of a number of common cancers. In fact, 13 different cancer types are increased by small amounts of weight gain with age. And beyond that, whatever weight we are, exercise reduces cancer risk. And the more exercise that people do, the fewer cancers they will get. We don't understand why, and that's quite complex. But these simple measures are really important in reducing cancer. If we go to the next slide, please. So the cancer services in Buckinghamshire have continued to be delivered throughout the pandemic. And this slide shows a number of treatments within our cancer day units. The blue line showing what we delivered in 2019 and the red line showing what we delivered in 2020. And unlike the referrals graphs, you can see that there's pretty much maintained delivery of cancer services throughout. And really impressively, our chemotherapy unit in ward moved from Stoke Mandeville Hospital across to Wickham and continued to give cancer care in Wickham throughout the pandemic. Next slide, please. I would like to stress that we've done everything we can to make our hospitals safe to attend. The first thing we've done is make sure you only have to come to hospital if absolutely necessary. I know that GPs have done this as well with the introduction of telephone clinics, and we're often using telephone as the first point of contact after a cancer referral. And that's to make sure we can get the correct steps, the correct investigations done as fast as possible. Using telephone and other technology has allowed us to reduce the number of people that are physically coming to our outpatients and are physically attending GP surgeries. That allows safe social distancing. And we've also had to reduce the number of visitors in hospitals, which again has had an impact on family members, but it is important to keep numbers down. All of the staff in hospitals and in primary care have got full access to personal protective equipment, or PPE, about which we heard so much of shortages early in the pandemic. We've got full access to the kit now, and we can protect you and we can protect ourselves. Everywhere has put in place increased cleaning, and we know how to clean hospitals well, and that's being done. We're really fortunate in Buckinghamshire to have Wickham as a site where there is very little emergency activity. And the Wickham Surgical Treatment Centre within the Wickham Hospital site is being kept as a protected area, free from patients with COVID and free from any staff movement that is not absolutely necessary. That's allowed us to carry on operating there through the majority of the pandemic with no patients becoming infected with COVID. And really important to stress that your safety is our priority in delivering cancer care. We can do it safely. We're really keen to do it well, and we're happy to work with you. Thank you.
Thanks, Andrew. So I believe before we go to the Q&A session, we will go to Ruth to say a few words.
Yeah, thank you, Andrew, and Zoe for passing to me. So I think that it really, Andrew was keen that I maybe just go through in very brief detail a little bit of focus around what we do as an alliance, and I think that's because we're relatively new organisations that are, I guess, hopefully gaining some traction, and we're certainly working, as I say, with those clinical and managerial teams to really look at how we are progressing cancer services. And so our TVCA is the Thames Valley Cancer Alliance. There are 21 cancer alliances across the country, and we work closely with 3 other alliances across the southeast of England. And really, as I say, our focus is really around how can we work together to ensure that treatment and diagnostics can be planned and delivered most effectively for all patients. And I think that certainly through what we've learned in COVID in the early days, we're now working really closely, not just with Bucks here this evening, but with other trusts across the Thames Valley to just ensure that as we move through the winter and into the spring, that everything that we learned through the initial COVID experience is being applied and enhanced really to support through this period of time. One thing that we do, and I may have an opportunity to come on and talk a little bit more about this, is, as Andrew said, some of for patients who were already in the system or for those that did come forward to their GP, we were able to maintain treatment and diagnostic pathways in a very secure way. I think this slide that's particularly telling, though, was the one that Andrew showed, where we saw how greatly reduced the number of patients were that were coming in during the initial lockdown. And I think it would be great to partner with Healthwatch, as well as those who are on the call tonight, to just think about how do we ensure that any patients that didn't come forward initially do come forward as we move through to the winter. So I'll hand back to you, Zoe, if that's okay.
It is, thank you. So we'll shortly move on to our Q&A session. This is your opportunity to ask the panellists any questions you have. We think we may get lots of questions and we might not be able to get through them all, but any that we aren't able to cover in this session, we'll ask the panellists to answer them after the event, and the answers will be posted on our website. Please make sure to type your question using the chat bar function. If you could use the all panellists and attendees option, then everyone else can see your question as well. A reminder that speakers, the panellists can't give individual clinical advice, so please don't share any personal details, and remember that your name will appear in the chat bar function. If you want to be anonymous, there is an option to modify this. We would also like to hear your feedback about this event. And in a moment, we'll share a link to a short evaluation survey in the chat function. It will only take a few minutes to complete, but your feedback will really help us improve our next event. We ask some optional questions about you, such as age, gender, and ethnicity. You don't have to answer these, but we would really like to hear your views on tonight's event. So to start off with, we've been sent some questions prior to this evening, and we will go through those before moving to the ones coming up on the chat bar function. So the first question is from someone saying, I would like to know what facilities there are in Bucks for people currently going through cancer. I'm 35 and got diagnosed last July. I wasn't offered any help to deal with it and wondered if there was a group that met up online, in person, and talked about how we're feeling and how it's affecting us. And Annie, I believe you're going to respond to this. think you just need to unmute, Annie.
Can everyone hear me now? Yep.
Thank you.
Okay, so sorry to hear about this patient's experience. In Bucks, we do have a cancer and information support service, which is based over at Stoke Mandeville, but most of what the service offers can be given over the phone or via email, and we will post the details of that service on the website. What that service can offer is signposting towards a whole variety of different support groups and give practical and financial and emotional support as well. There are a number of support groups that are running. A lot of them have changed how they're running. So instead of face-to-face, they're using virtual platforms like Zoom or Facebook. If patients also are in contact with their cancer specialist nurses, then they can provide cancer-specific information and signpost to support networks that way as well. Nationally, Macmillan Cancer Support have a 7-day support line service, and that runs from 8 till 8 every day. And they have online communities and different forums that patients can access as well. And we just wanted to also mention that we're launching a system-wide project on standardising reviews within 6 months of a cancer diagnosis, and then another review after and further 6 months within the community. And that will very much be looking at holistic care, physical, psychological and emotional care.
Thank you. And as I said, we'll collate these answers as well, so people will be able to refer to some of the places that you've signposted to there.
Thank you.
Next question. My husband was diagnosed with cancer during lockdown. After 2 operations, he's now on a treatment plan which goes into the new year, currently receiving chemo with radiotherapy to follow. My question is, if we go into another complete lockdown, will his treatment stop? I think that's a concern for lots of people. Cheryl, will you be able to respond to that question?
So, all our cancer patients fall into the clinically vulnerable group of patients because the chemotherapy we deliver causes immunosuppression, impairs their immune function, and likewise with radiotherapy as well. That will impair the immune system, and therefore they'll be vulnerable to severe COVID infections. For that reason, we've been asked when planning someone's treatment to consider or trying to balance the key issue of optimizing the treatment of the cancer versus the risk of developing severe COVID infection. Sometimes when we are treating the patient radically or with curative intent, when we're trying to cure them of the cancer, the balance is such that we would really want to pursue their treatment. Sometimes, however, the treatment we are offering is not going to provide a cure and may be of minimal benefit, and the risk of severe infection outweighs the benefit. So in those circumstances, we will have a discussion with the patient and the family about whether it really is worth pursuing further treatment. So that's a general approach we take for most patients. In that particular question, I'm not entirely sure of the specific circumstances, but that would be the approach the clinician would probably take with the family and patient.
Thank you. Okay, another question. To what extent has COVID introduced delays to cancer treatment? For example, how does the time between initial diagnosis and the start of treatment over the last 6 months compare with the same 6 months last year? And I think Ruth is going to pick this one up.
Yeah, thanks, Zoe. So I think Andrew actually in his presentation did a little bit of describing some of this already, but we certainly worked very closely with cancer teams across not just Bucks, but the Royal Berkshire and Reading, Oxford University Hospitals, Great Western Hospital in Swindon and Milton Keynes, through the early part of the pandemic to really try and establish what we've called COVID secure pathways. And what that essentially meant was that there were dedicated sites where we continue to undertake cancer diagnostics and treatment that were away from where essentially away from where COVID patients were being treated. This included increased protective equipment for everyone, cleaning, extra cleaning, as well as the need to obviously look at COVID swabs for all patients to ensure that this could continue. And what we actually saw was that for patients in the pathway, the time in which they were diagnosed and subsequently treated was in most cases not significantly different. But I think what we do know, as I said just earlier on when I came on, is more that we anticipate that there are patients that perhaps didn't come forward. We know that prostate is a particular pathway that has had a slow return to the normal numbers of patients that we'd see on those pathways, as well as a couple of other tumour sites. And so I think the question more that we're now really working towards is to ensure that we can really encourage anyone with those symptoms that Andrew described, as well as other cancer symptoms, to please come forward to their GP to ensure that we can safely manage those cancer pathways. And so, as I say, at the moment, for patients in the pathways, we're able to diagnose and treat largely in a similar fashion to that before we had the COVID pandemic. But really now we want to see all patients coming forward, and there will be the challenge as to how we continue to maintain those timings to diagnosis and treatment through the winter period. The use of things like virtual technology, telephone and video consultations, we think are of real significance. But as I say, those pathways that are COVID secure are in place and will continue to operate across the Thames Valley. And we're confident that will help support cancer services through the winter. Back to you, Zoe.
Thank you, Ruth. And actually that leads on, we do have a question about using technology. So I'm happy for my oncologist to consult with me remotely, but when we'll be able to communicate by Zoom or MS Teams rather than by telephone. And I think Annie was going to pick this up.
Yes. So we did have to change quite quickly how we could review patients during the COVID pandemic, and that changed to a lot of telephone reviews for many patients, with a small number of patients needing face-to-face still. Across the trust, there is going to be a rollout of Microsoft Teams so that we can use that for virtual clinics. And within cancer, we hope to do a combination of both face-to-face clinic consultations when needed, and then virtual clinics will continue using the Microsoft Teams when it's in place. And that's hoped to be in place by the end of January 2021.
Okay, thank you. And then the last one of pre-asked questions. When someone has been treated for cancer at a hospital which is not their local hospital, who's responsible for generating the follow-up checkups? Is it the hospital which treated the cancer, the local hospital, or the patient's GP? And Cheryl, I believe you're going to.
Yes, so it's generally the treating hospital that would generate their follow-up. They may have an arrangement with the local hospital for subsequent follow-up, but that will be arranged obviously prior to all that.
Okay, thank you. So now we're going to go to the questions on the chat bar. I've seen quite a few come in, and I'll try and go through these in order. And some of them overlap with questions that have already been asked, so do bear with us. But a reminder that any questions that we don't have time to cover in this session, we'll pick up with the panelists afterwards, and we'll make sure that they're included in the Q&A session, the Q&A summary rather, that will be posted on our website. So a question, panelists, I'm not sure if you can see these. How are you going to be dealing with what looks like a second wave of SARS COVID infections and maintain services after any backlog of appointments?
Zoe, I think I'll pick that one up. I think the important message here is that we are planning to maintain cancer services throughout a second wave. If we have to reduce cancer services at all, we'd be incredibly disappointed. We've learned a huge amount during the first wave about how to keep patients safe, how to keep our staff safe, and how to adapt into this new world. And we feel that we've got our theatres running well, we've got our radiology, imaging, our endoscopy services running well with all the proper protective kit, and we should be able to keep going through a second wave. It will still be safe to come, and that's what we're endeavouring to do.
Thank you.
Sorry to interrupt you, Zoe. I think from a system perspective, if you don't mind me just picking it up. So part of my role is to look at the system perspective of services, and the clinical commissioning group and the hospital are working in unison as a combined group to really look at restoration and recovery, how we can deliver services in a COVID safe way, and that's really been the priority throughout this whole process. So there is a strategy around that. We have developed a set of principles of care which align to priority, keeping people safe, a system around closing that inequality gap, ensuring that harms are minimised and understood and mitigated against. And within that, we're looking at demand and capacity planning. So if there is more demand, we're learning how to model and then manage that in a way that will allow, as Andrew said quite rightly, to maintain those priority services such as cancer. So it's internal work going on at the hospital, but system work as well to make sure our community and population is as safe as possible.
Okay. Thank you. Going to another question on the chat bar. What percentage of cancer screening could potentially be conducted via a mobile unit at patient locations rather than the patient attending hospital? I don't know if this is something you've explored.
So I can touch on this a little bit. We're certainly, or primary care is delivering the cervical screening services. In terms of what percentage, I think that's really difficult because it's all about which services are available. In other words, have we got the facilities to purchase and house those mobile units? So I think it's really difficult in terms of answering that specific question around percentages, but in theory, yes, you can bring in mobile units for breast cancer screening, for example. In terms of bowel cancer screening, what we're really wanting people to do is, if they get their kit in the post, then to respond to it, and that's our major concern. And once those kits are returned, then we can manage them accordingly.
So next question, someone asking why patients have to go to Oxford for treatment. Who wants to pick that up?
Sorry, I can touch on that. So I suppose if we take cancer treatments and we look at this systematically from surgery point of view, where we need complex surgery, patients need sometimes to go to Oxford because we just don't have the surgeons who perform those high volumes of those complex surgeries. So it's really to really provide the best care for the patient. Likewise, for chemotherapy, there are some very complex chemotherapy regimens that we are not able to deliver in Bucks, particularly for those rare cancers. So in those circumstances, we feel it's in the best interest of the patient to have their care and their chemotherapy delivered in Oxford. And radiotherapy overall has to be delivered in Oxford because we just don't have the radiotherapy machine in Bucks.
Okay. Thank you. Next question. I understand that because of COVID, there was a move from drip to tablets. Is this being reversed, and how effective is one against the other? A question about treatment.
Yeah. So once again, I can answer that. So yes, there has been a move from drip to tablets for some chemotherapy drugs, which come in two different formulary methods. So there is not a lot of difference in effectiveness between the drip or tablet form of these particular drugs. But what it does do is it provides the patient less contact if we are able to give them tablets, and therefore reduces their COVID risk.
Okay, thank you. So I think Andrew touched upon this, but there's a question about what information on COVID security will be given to patients and their relatives and what to expect when attending appointments, and what are the expectations of patients stroke relatives on attendance at appointments. Anyone want to pick this up?
In our clinics, we try and schedule the patients carefully so that there's not too much of a wait between patients. We also encourage patients to come alone to face-to-face appointments unless it's a discussion that is of a new diagnosis or new treatments, in which case we sometimes encourage patients to bring at least, well, just one relative and not too many to the appointment. On top of all that, obviously, members of staff are using PPE to make sure that we're not also to make sure that we're protecting patients and their families as well.
Okay, thank you. Next question. The referral chart shows a return to above the 52-week average, but what specific plans are there to catch up with everything below the curve?
Yeah, I'll pick that one up. It's a really good question. And going back to that referral chart, approximately 4,000 patients who we would have seen at the normal rate of 400 a week have not come to us in the hospital during the course of the pandemic. We have picked up referrals back to where they normally were now. There's a big question. We all expected more patients to come at this stage, I think it's fair to say. And there's a really big question as to what will happen. In that 4,000, there's probably 250 patients with cancer who we would normally have expected to see that possibly haven't come along. The other group of patients, the other 3,500, they may have symptoms which were quite short-lived, that they had in March, they had in April, but they had gone by May, and therefore they've never gone to their GPs and had never needed to be referred. And that's often the case with these symptoms, which are quite vague and may or may not represent a cancer problem. That if people present very quickly to their GP, they will be referred absolutely appropriately and will investigate them appropriately. But actually, if we waited 2 or 3 months, sometimes those symptoms would resolve. And the difficulty is you just can't tell. And we'd rather be safe. We'd rather see people early. We'd rather check them out early. We'd rather diagnose cancer early. So my gut feeling, and there's no evidence around this, is that the majority of the patients that we have needed to see have come in. But if you've got any doubts whether you or a family member should come, please go and see your GP.
Thank you. Next question is quite a personal question, so do tell me if you'd prefer to pick this up outside of this session. It's from someone who was diagnosed with last July with breast cancer at 34. She's had IVF, mastectomy and chemo and struggled, but because she also has bulimia, she's been told she needs a mental health team, but she feels that she needs help coming to terms with cancer, not the bulimia. Don't know if anyone wants to pick this up.
So I'll pick that up. I'm absolutely sorry to understand what you've gone through. I think that's a really difficult thing to have had to endure. Clearly the whole system is really wanting to focus on people who need help, and if you need help with respect to coming to terms with your cancer from a psychological perspective, certainly that list of services which Annie talked about at the beginning, I think is a great start. So that includes the website, Macmillan websites, and the cancer support nurse, but also really importantly to link in with your GP. And GPs are seeing patients face to face as well as by video and on the phone. And I think if you're struggling, absolutely make contact with somebody and they'll signpost you to the right person. What I don't want people to do is to be suffering at home in silence.
Okay, thank you. So the next question is a question on the percentage. So what percentage of Bucks cancer patients are referred to specialist hospitals outside of Bucks, and how can we be assured of their safety in the COVID context? Anyone want to pick this up?
I'm happy to give it a stab. I think it's a really difficult question, really, because I think we're meaning the percentage of people referred directly to hospitals rather than via Buckinghamshire Hospitals Trust. And without actually digging out that data, it's going to be difficult to give you the answer here. However, the majority of patients tend to choose their local hospital trust purely because there needs to be a whole series of investigations, etc., which may or may not require a trip or two to the hospital. Obviously, most hospitals are now trying to offer what we call a one-stop shop service or a telephone service, as Andrew talked about at the beginning, just to make sure we're as COVID safe as possible. And then obviously those patients after then will require treatment if they're diagnosed with cancer. So most people are choosing their local hospitals. However, we do collect data on patients who are referred outside of our local area. And obviously people who live closer to other hospitals like Wexham Park or Milton Keynes will obviously want to go there as well. So we do collect that data as a system. And we do link in with other hospitals in terms of our quality team, etc., to make sure, to assure ourselves as commissioners and as a system that our patients are served well, whichever hospital they go to.
Thank you. So the next question, so given that 13 out of 14 tests are negative, the impact of obesity on cancer diagnosis and research showing the importance of diet in preventing / managing cancer, do you think more needs to be done in terms of community education? This could save testing costs, anxiety, etc., associated with benign tumours.
I'm happy to pick that up as well. Absolutely, this is something we're trying to do, not only in cancer care, but across the whole spectrum of disease. So if we can prevent more cancers, if we can prevent more cardiovascular disease, if we can prevent more diabetes, etc., then the healthier our population is going to be, and the less costly that's going to be, and the less suffering there's going to be. And yes, absolutely, education is part of the story. Obviously, health and the NHS will account for some of that or be responsible for some of that. But there is something called the wider determinants of health. And that really means that healthcare only accounts for about 30 to 40% of our health outcomes. Most of our health outcomes aren't to do with the NHS as such, but are to do with lifestyle and exercise and happiness and education and all of these sorts of things, which involves local policy and government policy. So we absolutely will play our part and do play our part and want to educate more people. But this is about the population coming together as a group, as everybody in our country and in our county, to work together and to look after each other and to look after themselves as well. But absolutely agree with you, there should be more education, and we try and do that as much as we can. I think most people on this panel have been on the radio and local papers just to try and educate the public. But of course, more can always be done.
Okay, thank you. And just while you're there, Raj, could you, we've had a question asking you to clarify what system is, just for people's understanding.
Apologies, yeah. So in the old days, we used to have this, I think divide is the wrong word, but I'm going to use it just to illustrate, where we commission services from providers. So the commissioners will sort of understand and prioritise what we want to deliver, or prioritise in terms of the budget that we have, and effectively purchase those from providers, i.e. the hospital. But now, and over the past number of years, we've worked together as providers and commissioners really to come together with a group of other stakeholders, including the Alliance, including charities like Cancer Research UK and Macmillan, all coming together with patients to try and find the best solutions for Buckinghamshire. And that has proved very fruitful. We have a very effective cancer strategy. We won an all parliamentary award for increasing first-year survival in cancer a few years back. And we're fortunate in Buckinghamshire that the commissioners and providers, i.e. the hospital, Buckinghamshire Hospitals Trust, have a very good relationship. And I think that will only serve our patients well.
Thank you. So next question, someone is concerned that they've heard that if radiotherapy hasn't started, it may be put on hold again if there's another lockdown. Can anyone pick that up?
I don't deliver radiotherapy. This is delivered in Oxford. But from what I can gather, that shouldn't be the case, particularly if it's radiotherapy being delivered to cure someone or eradicate the cancer. It should not be delayed.
Okay, thank you. Next question. Cheryl talked of sensitive discussions that need to take place to look at vulnerability and potentially discontinuing treatment. Will these discussions take place face to face, and will patients be able to be accompanied by someone in these sessions?
Yeah, we're very conscious that there are lots of different types of discussions that need to be taken place face to face. And these include a new diagnosis, explaining the treatment plan, discussing the types of treatment, and later on when discussing stopping treatment or discussing alternative treatments. All these sort of scenarios will require a face-to-face consultation, and we make sure that that is the case. We also do encourage people, patients, to bring one family member with them, because it's always helpful to have someone else to listen into the conversation and also to add to the conversation. I should also say that a lot of clinicians now also send copies of their letters to their GP to the patient, detailing what's been discussed. So you've got a written record of what's been said on that during that consultation.
Okay, thank you. So next question. Are there any trials going on that people were taken off? If so, when will they be able to rejoin? Who can pick this up?
So there were a lot of trials put on hold during COVID. Any trials that needed to continue did continue. A lot of the research nurses and teams that were working on those trials were then diverted to look at the COVID trials and recruit to those as well. So trials are beginning to be picked up again, but any trials that needed to keep going also kept going as well.
Okay, thank you. So the last question that we have at the minute, unless someone types one over the next few minutes, if there's a possibility of symptoms being short-lived as a reason for low pickup referrals, are we seeing a higher percentage of the actual referrals being cancers?
Thanks, I'll pick that one up. It's a really good question, and the answer to that is yes, there is a slight pickup in the number of patients referred being diagnosed with cancer, but it's gone from 7% just up towards 8%. It's not gone any higher, so it does not explain that full gap. And it's slightly early days to be looking at that figure as a percentage as well, because we haven't got enough numbers coming through yet. But there is a sense that a few more patients are being diagnosed, but it's small numbers.
Okay, thank you.
Can I just pick up on that as well, please, Zoe? So just stemming on from that, really good question is the concern that a lot of patients or some patients have presented late with their condition. And so we have seen an increased admission rate through the A&E departments for people who didn't present early enough with their cancers and therefore have presented in crisis in the A&E department. And those patients, unfortunately, will have a worse outcome than those patients who, than if they had presented early via their GP with their cancer symptoms. So really, it's a plea that if you do have cancer symptoms, as Andrew was talking about earlier, then do seek advice, because the earlier we do the referral and investigate patients, then the greater the survival rate.
Okay, thank you. So we have had a few more questions come in. So can you say anything about whether the changes proposed for the Mount Vernon Cancer Service, will this impact on people from Bucks?
I'm happy to start, and then maybe Annie or Cheryl would like to come in. We do send a few patients to the Mount Vernon Cancer Centre, particularly for radiotherapy and some specialised prostate treatments. We are aware of the proposed changes there and the potential takeover by another trust, and are keeping an eye on it. We are going to ensure through those complex negotiations that services are maintained wherever possible for Buckinghamshire patients and delivered at high quality.
Thank you. So next question, what are the treatment delays like if I'm referred to hospitals out of the county, for example, Oxford?
Ruth, can you pick up that as a...
Yeah, sorry, just coming off. Thanks, Andrew. Yes, so as mentioned earlier, we work across all of the trusts in the Thames Valley region, and certainly Oxford, being a specialist centre, does obviously take a large number of patients from across Bucks. We're working closely with all the trusts to monitor very closely those treatment pathways, and certainly are working to ensure wherever possible that those patients are moved as quickly as possible. I think there are some ongoing pathways that we're really focused on to ensure that there aren't any delays, but that is something that we will continue to work with Andrew and colleagues across these clinical pathways. It is an area where we need to have additional focus just to make sure that those delays are wherever minimised. So I think that again, through the COVID pandemic, we've been able to work more closely really to understand those pathways, and I think we've started to see improvement already, but it is something that we will be working with all trusts carefully to monitor as we go through winter.
Okay, thank you, Ruth. So next question, when will complementary therapy start up again?
Shall I take that one?
Yes, please.
So unfortunately, we had to put our complementary therapy services on hold quite quickly at the beginning of the pandemic. We haven't been able to reinstate those. Obviously, the types of treatments that we offer are very close contact with the patient. So that's the therapist and the patient having to be in very close contact. And the risk with that at the moment is too significant for us to bring those services back in. We don't have a time frame at the moment. We are reviewing it regularly, but at the moment, unfortunately, we're not able to reintroduce those services.
Okay, thank you. So the next is more of a request than a question. So my GP practice is good at sending SMS messages for closure, for training, etc., but little around encouraging presenting with symptoms or understanding the risk of delay versus COVID concern. Can someone give them a nudge?
Shall I take that as a GP? I think that's a really interesting sort of topic to debate, and I think we could be here all evening just talking about that. Some of the feedback we've had from patients is that there's too much information being shared with them, and some say there's too little, and I think it's a really difficult balance. So what we tend to do is rely on the NHS comms team, both nationally and regionally, to give standardised comms to patients to make sure that they are written clearly and concisely with clear messages, and that's gone through a proper approval process by the comms team, and therefore there's standardisation across the whole of the region.
That's great, thank you. So next question, do people at end of life have as many options as they did before COVID?
So shall I take that?
Yes, please.
Yeah, so it again, it's a really good question, and even before COVID, as well as during COVID, what we really try and do is to predict when people are moving towards their last phase of life, which might be a year, it might be 6 months, it might be 2 years. And then what we encourage our clinicians to do is to have those individual discussions with those patients about where they think things are heading, what they would like going forward, and involve them in choices and discussions around their end-of-life treatment. And therefore, it's really important for us as healthcare professionals to ensure that the carers of patients and patients themselves are absolutely at the centre of our conversations. So those choices are made by patients about themselves rather than having discussions and decisions made about them without. And that's a really critical agenda for us. So it's really person-centred care is what we're trying to practice.
Okay. Thank you. So, not a question as such, but would echo that my GP practice has done a great job of being clear about attending the practice during the pandemic, but I would welcome some comms now to encourage people to present at practices early with potential cancer symptoms.
So Ruth, I wonder if it's worth, maybe that's something we should be discussing at one of the Alliance meetings, just to get some discussion across the whole region around how we can address that issue.
Yeah, I think absolutely. I was going to come in and Lucy, thank you for kind of posing that, because I think it's something that we know that there have been some national campaigns where they have clearly talked about the NHS being open for business and help us help you. But I think that what we are very keen to do as an alliance, and really I'm asking for anyone who's involved this evening if they have any thoughts around what does that look like? How do we get to a really broad, and it's important that we recognise here that equality and access is something that existed pre-COVID, and the inequality in how patients come forward and the public. So I guess it's something that we're very keen to focus on. We have already had some focus around, particularly as we mentioned right at the top of today, around the prostate pathway, and ensuring that people know to come forward with any symptoms related to prostate cancer, but it goes across all tumour sites. We would love to work with colleagues across BUCS and beyond around what do those comms look like. What style of comms are we looking at? You know, not everyone digests information in the same way, but you know, if there are those patients that haven't come forward, how do we make it clear, as well as we move through into winter and potentially a little bit more COVID again, how do we encourage people that they really must come forward if they have any of the symptoms related to cancer? I think that we have started to do a little bit of this with our primary care lead, Dr. Anant Sachdev, who did some patient-focused videos around what signs and symptoms to look out for. But I think there's much more we can do through social media, through community groups, and I welcome any thoughts in the comments box now or after the meeting around how we can do more around this. And I think certainly Raj, very happy that we have a dedicated meeting within the Alliance to do that. And Zoe, from your perspective, any thoughts that you have around this as well would be very welcome.
Okay, thank you. There's another comment in the chat box echoing the need for communication and encouraging people to present when they have symptoms. Someone's asking, is there anything we can learn from other countries where people do present early?
I was, before I go on mute, I was just going to mention the Australian way in all of this, which I picked up through LinkedIn actually, and some of their campaigning is called "Don't Wait, Mate," and you know, was a very direct message around, you know, we need to be able to do tests to be able to support anyone that's coming forward. And I just thought I'd position that out here at this meeting, in that, you know, there are ways in which we can also look at the words we're using that perhaps resonate with people. So again, just thoughts really, but I think that the way in which we look to target anyone across the BUCS population is something that we can learn a lot from those on the call really, and from people working across different sectors. So I think that's just an anecdote more than anything from another country, but I do think that perhaps we need to just be a little bit more focused and obvious in what we're asking. And I again would be interested to hear from any of the other panelists if they have any examples from other countries, but also from anyone who wants to pop anything in the chat box.
So can I just chip in here as well? There's an issue in Buckinghamshire around equality, as Ruth has alluded to, and it's really clear that some pockets of our population, particularly those in sort of central Aylesbury, central Wickham, Cheshire, which are more deprived, those people living in those areas tend to go to their GP less often. They're less likely to be referred to hospital, and they're more likely to come to the emergency department with a cancer problem. And we're keen to address that, and we're going to be doing some work with our GP colleagues and the Cancer Alliance to try and understand this process and work with local charities to see what we can do differently in these areas to drive up referral rates in these poor areas of the population.
Thank you. And there's an offer in the chat box from Carers Bucks to work alongside PCNs and CCG in terms of promotion. That's something to bear in mind, Ruth and others. Are there certain sectors of the population in Bucks who are not coming forward for cancer screening more than the norm, and have these differences widened during the pandemic?
So I can make a start on this. So yes is the answer. That there are certainly populations who aren't coming forward for cancer screening or cancer symptoms. And that's not just cancer symptoms, of course. We see that across a whole spectrum of diseases, including cardiovascular disease. And we've been looking at this for a long time. It's certainly a key agenda across the Restoration and Recovery Programme, which is the programme looking at how we deliver care in a COVID-safe way. One of the programmes of many includes some focused contractual work for GPs, helping them, supporting them to focus on patients who don't attend their screening programmes. And indeed, what we're also going to be doing is doing some population health management, and that's really looking at our patients from a population perspective, looking at those areas which don't attend screening compared to others, and just looking at the root causes of those, and then to try and close those gaps. So there's a huge amount of work that's going on in these areas to try and close that gap. So it's a very much recognised issue, and a very much and a very active piece of work as we speak.
Okay, thank you. So we've come to the end of our questions, and we're also running out of time. So I do hope I've covered everyone's question. If I have missed anybody, then we will, as I said, we will get answers and be posting those on our website. I also see that a couple of people have had issues with the sound quality, so I apologise for that. But before we close, a few final points from me to let you know what's happening next. We'll be posting a recording of this webinar on our website, and we will email everyone a link. Everyone who registered will receive a link. If you didn't have a chance to do the survey, please do go to our website, where there'll be a link there, and complete it when you have time. As I said before, we're really hoping to run more of these events, so your feedback will be really helpful in helping us to plan and improve these. We'll also include a summary of the feedback in our report. But before we go, a really big thank you to all our panellists for taking part, and to everyone who's joined us this evening. I've personally found it really informative. If any of you would like to leave feedback on any Bucks Health and Social Care service, please go to our website at www.healthwatchbucks.co.uk. And finally, we appreciate that cancer and cancer services can be an extremely difficult topic to discuss. So if this event has raised particular concerns or worried you in any way, please do email us at info@healthwatchbucks.co.uk, and we'll do our best to help. So thank you all. Good night.